Bismillah ar-Rahman ar-Rahim. Our lecture today will be on the role of MRI or cross-sectional imaging in gynecology, and this is for clinicians mainly, in order to know when to request CT, when to request MRI, and so on. First, we will start with the adnexal masses. The role of MRI and CT in adnexal masses. This is the normal ovary as we have to see on MRI. This is the normal size of the ovary with hyperintense follicles on T2, and this is hyperintense signal on T2 means fluid. So the follicles have fluid signal, and this is on T2, they are bright. And one of the follicles is dominant follicle in the left side here. So this is the appearance of the ovaries on MRI. Of course, there is a wide spectrum of the appearance of MRI regarding the size, according to the age, according to the parity, but will not be in this lecture. But we have another lecture on the channel on the normal anatomy of the ovarian on MRI. Of course, I will not go through the ultrasound, because I think we are all experts in ultrasound. But the ultrasound, it is the first modality of choice. And on ultrasound, on combining the morphology, combining the morphology of the lesion and together with the color Doppler score is very important in the assessment of adnexal masses. So combining morphological assessment with transvaginal sonography with color Doppler features has allowed accurate assessment. The overall vascularity was classified as high, low, and intermediate, and nowadays we give it a color score. Like this one, there is here, it is a color score seen here, this is color score 4 to 5, because we have large central vessels inside this lesion. But what about the 3 and 4D? Because many of the clinicians requested 3D ultrasound for gynecological assessment, ovarian, neoplastic lesions. But it's not so, the use of color Doppler is very important. But the 3D ultrasound is just specify the lesion more, but it is not mandatory. It's not the one which reach a diagnosis. And so also in cases of endometriosis, for example, the 4D ultrasound does not diagnose endometriosis. If you suspect endometrioma, you have to do MRI. So the 3D ultrasound just improve the detection of morphological abnormalities indicative of neoplastic ovarian masses in particular. If there is a small papillary projections, if there is focal neural irregularity, we can detect by ultrasound. We have also the dynamic contrast enhanced transvaginal, but it is in Egypt here, we didn't use so much because the contrast is not available. But if we do the contrast enhanced transvaginal, you will find a curve like that we seen in MRI. In malignant lesions, we have a rapid rise and wash out as we see in the curve of MRI. This is apparently normal ovary, but it shows marked enhancement on post-contrast. So this is early malignant process in this ovary. And this is very important in detection of early diagnosis of ovarian neoplastic lesions. What is the role of cross-sectional imaging? Cross-sectional imaging can be used for diagnosis, characterization, and surveillance for management of the cases, to determine the site of origin of a pelvic mass, assessment of primary tumors, the pattern of extra ovarian spread. So this is the most important points that we have to do in MRI. First, I will give a spot on the role of CT. The role of CT in gynecology is not so good because it cannot characterize. It can diagnose and it cannot characterize in most of cases. We have to do MRI. But we have some cases that the CT can be enough, like the diagnosis of mature cystic teratoma. If we have here, this is a case of mature cystic teratoma. We have a complex left adnexal mass with a tooth-like appearance inside. There is fat. How to know this is fat? In radiology, we have to measure this by Hounsfield units. But if it is not measured, you have to compare with the other shadows in the field. Here we have, this is the urinary bladder showing fluid signal. This is part of the mass, have fluid signal, the same. And then this is the fat of the pelvis. And this is the fat inside the lesion. So comparing, this is fat. So this is a fat-containing lesion, multilocular, and showing a tooth inside. So this is a mature cystic teratoma. There is no enhancing mass is seen inside. And when you see there is enhancing mass or not, compare with the myometrium. This is the uterus, and this is the enhancing myometrium. But here inside the mass, there is no enhancing lesions inside. Of course, we have to go through all the cuts, not only specify one cut only. Another entity important to diagnose by CT, and usually this is encountered in the emergency department when a case coming with acute pelvic pain, and we have done ultrasound and we suspect that it is a pelvic abscess of enteric origin. And this is the lesion, and this is surrounding stranding of fat, and then we found the cause. The patient has diverticular disease of the colon, and this is a peridiverticular abscess. Again, if you look only on one cut, you may say that it is a tube-ovarian complex or tube-ovarian abscess, because the CT is cannot characterize 100%, especially if we didn't see accurately the ovaries. But when we found the cause here, when we search about the other abdominal cuts, we found that it is a peridiverticular abscess due to diverticular disease. Again, the CT is important for evaluating the extent of disease and to determine if this mass is clinically resectable or not. We can predict the outcome. Peritoneal metastasis being the most first presentation, CT is frequently fails to see small sites of peritoneal spread, and this is very important because sometimes we didn't see omental disease on CT, and the clinicians say that no, or the surgeon, when I opened there was omental disease. So omental disease sometimes could not be seen by CT if we have small peritoneal or diffuse peritoneal spread, sometimes could not be detected by CT. Like this case known to be malignant ovarian, bilateral malignant ovarian. We have here the all the criteria of malignancy. We have thick, it is bilateral, more on the left side. We have thick septations, we have thickened wall, we have enhancing solid components. So this is malignant lesion. This is ORADS 5. And again, by CT, we detect that there is an omental. This mass is attached to the anterior abdominal wall with extra ovarian spread. So we have also here, there is an omental disease present. So here we can, from CT, we can detect if it is overt malignant process like this. But still, if we have small peritoneal spread, we could not detect accurately by CT. Or by what? By PET scan. By PET scan is very important in these cases. In premenopausal women, the amount of fluorodeoxyglucose uptake in the ovaries varies with the phase of menstrual cycle. With physiological uptake, particularly in the early luteal phase, and this is very important if you do PET scan In a patient in the childbearing age, then this is normal. This is the normal corpus luteum appearance. And if you return back to the reference CT image, you will find the corpus luteum. Here, this is the corpus luteum. So this is the typical appearance, but in postmenopausal ovaries, it is not acceptable to have any ovarian uptake. So any ovarian uptake in the postmenopausal, it is pathological, whether benign or malignant. This is the omental spread here. This is an omental cake. You see, it's seen by CT very well. If we have omental cake, very, very large omental cake. But if there is a small peritoneal implant like this, if you go to the reference, you will find that you could not see it. So it can detect all the omental deposits that can be seen. So this is very important. PET MRI, PET CT versus PET MRI. Of course, we have here not we have no PET MRI, but the MRI, as we ever say, that it is good characterizing modality. So there will be better characterization than CT also in PET scan. We can find the spread more. We can find correlation مع MRI here in this cervical carcinoma. The CT has a mandatory role in acute pelvic pain. So in acute pelvic pain, CT is important. And this is in the emergency department we can do. We have here cervical motion can be elicited by vaginal probe, and we can find the site of pain, and this is by clinical examination for gynecologists, but we by ultrasound we can detect the site of pain. We can detect is this site of pain uterine or adnexal tenderness. The most common is the PID or the tubo-ovarian abscess. This is a case of PID. Here there is tubo-ovarian complex in the adnexal region. CT in pelvic inflammatory disease. A CT in pelvic inflammatory disease is very important. In early PID, the CT findings can be obscuration of the normal pelvic floor fascial planes, thickening of the ligaments, cervicitis or oophorytis and salpingitis. All this can be detected by CT, also can be detected by ultrasound, of course, at the first. Accumulation of simple fluid in the endometrial cavity, fallopian tube, and pelvis. This is the normal uterus. This is the normal endometrium on CT. The endometrium for CT is usually non-enhancing. So it is usually hypodense in comparison للnormal myometry. Here, this is a case of pelvic inflammatory disease. Note here bilateral multilocular cystic lesions with thick septi, stranding. There is indistinct fat planes between the uterus and these lesions. So this is a case of tubo-ovarian inflammatory process or PID. What is the role of MRI in PID? Because of the superior tissue contrast, MRI can distinguish hematosalpinx from biosalpinx. In CT and on ultrasound, we cannot distinguish. But on MRI, we can differentiate between hematosalpinx from biosalpinx. So, if you want to characterize blood component, then MRI. Can differentiate a tubo-ovarian abscess from possible ovarian neoplasm. And this is very important entity, because sometimes when the tubo-ovarian abscess is chronic, sometimes we cannot differentiate from borderline ovarian tumor with multilocular septi and thick septations. The patient usually take antibiotics, so the fat stranding is not so obvious. And so it can be a differential diagnosis between tubo-ovarian abscess and ovarian neoplastic lesions. And MRI can detect complications in the presence of urinary complications, other complications that we can see with the PID. Non-gynecological causes also can be seen on CT and also on MRI. For example, if the patient is Pregnant, we cannot do CT, but we can do MRI. Other causes, other non-gynecological causes, like lower quadrant pain migrating to the umbilicus, bladed compression is by ultrasound is very important, but sometimes ultrasound is inconclusive, and here we can do CT. This is ultrasound also. This is the appearance of the normal blind-ended appendix with laminated wall. Usually the neural thickness is 6 millimeter, so this is important. But if we could not see by ultrasound, we cannot exclude. We must correlate with the clinical, with the laboratory, if there is increased leukocytic count or not. And this is the target sign, the normal appearance of the appendix on ultrasound. In appendicitis, ultrasound is not conclusive, so we can correlate with the clinical and laboratory findings. CT is important in atypical sites. For example, the subhepatic appendix, we could not see by ultrasound, but we can see it by CT. According to the ACR, CT is the most accurate imaging study for evaluating suspected acute appendicitis, alternative etiologies of the right lower quadrant pain. But provided that the examination is done well, we take thin cuts and we try to see the appendix. We can give oral and intravenous contrast in order to detect the site of the appendix. Advantages of MRI in appendicitis. What is the role of MRI in cases of suspected appendicitis? Better visualization of the abnormal appendages and the adjacent inflammatory process. Visualization of the appendix in atypical location. Also, as we see by CT, we can see by MRI. Operator independence and ease of examination of patients who are obese. And we add more patients, pregnant females. We have also urinary related symptoms of acute pain, and this is very important. We can detect by ultrasound. This case was diagnosed many times by ultrasound as an adnexal echogenic cyst, but it was just hydrocele, urethrocoel inside the urinary bladder with a stone in the lower ureter, and the ureter is dilated like this one. CT also can detect urinary causes like small stone, and this is also very important in pregnant females. If you suspect, you have to take very limited cuts in order to see if there is a stone or not. But we try by ultrasound first to detect the cause of pain. What is the disadvantages of CT in gynecology? The patient exposure to ionic radiation. So try to limit the use of CT as much as possible, especially in young females. Possible allergic reaction to iodine contrast agents, and this is very important. Worse soft tissue visualization comparison to MRI. If I want characterization, in cases of endometriosis, don't say endometrioma from ultrasound ever, and you have to do characterization by MRI. Pelvic pain and abdominal enlargement. This case was pelvic pain and abdominal enlargement. CT was requested, but CT here is not the modality of choice. Why? Because we didn't characterize. But from this cuts, I see that the uterus here is clawing around this lesion. There is claw sign. So I suspect that this is degenerated subserous fibroid. But it is difficult from CT. But when we do CT, we ask to do sagittal and coronal reconstruction. Because in sagittal and coronal reconstruction, we can detect the relation to the uterus. This is the coronal here. This is the uterus. Here, this is the claw sign that we used to see in uterine lesions. When the CT is not conclusive, just you have to do complementary ultrasound. We have to do second look ultrasound. Here the ovaries are normal, completely normal ovaries, This is excluding ovarian masses. And here this is the mass, cystic mass, related to the fundus of the uterus. And there is bridging vessels from the uterine. So this is a degenerated subserous fibroid. So in acute pelvic pain, to summarize, examination and lab is mandatory. So please, for clinician, try to cover this first before you send the patient. Ultrasound and Doppler, it is the primary imaging modality of choice. It can detect the source of pain, and it is very important to assess causes of pain in pregnant females. But the limitations is operator dependent always, and patient obesity. And sometimes during pain we find many gazes in the pelvis and we could not see well the adnexal regions. If the ultrasound is inconclusive, needs confirmation, or lack characterization, if we suspect, for example, endometrioma, then we have to characterize. And if we didn't see the extent of pathology or the complications, then ultrasound here will not be enough. We must do CT or MRI accordingly. MRI appropriate sequences in pregnant females for tissue characterization, confirming ectopic and torsion and obstructed uterine anomaly in young females, atypical appendicitis. This is very important. CT contrast or non-contrast. Non-contrast, of course, we use it in the urinary causes. In inflammatory causes, PID, tubo-ovarian abscess, appendicitis, and suspected urinary stones. Another entity that usually encountered in emergency is the imaging of the postpartum complications. When to do cross-sectional imaging? First, ultrasound is the first line modality, but the evaluation may be limited and the results are sometimes inconclusive. And this is very, very important if the patient coming in the early post-cesarean, for example, and she has collection in the pelvis. Is this collection blood or inflammation or uterine dehiscence? This is very important to consider. CT provide additional information, and it is the technique of choice for imaging most postoperative and extrauterine complications. MRI is not usually performed in the emergency department because of limited availability. But sometimes in the emergency department it is present. Pelvic MRI can be performed if CT findings are inconclusive. And the most important is that you want to know if there is uterine dehiscence or not. Imaging of the postpartum uterus. The patient clinical history is extremely important to differentiate dehiscence from normal appearance of the uterine incision. You must know the normal. What is the normal that we have to see? Accompanying signs such as free fluid, large bladder flap hematoma more than 5 centimeters, presence of pleural effusion, bowel distension, most likely بتبقى ileus. The sensitivity of CT is poor for diagnosis of uterine dehiscence. So in such cases, we need to ask for pelvic MRI, which can provide better diagnostic yield than does contrast-enhanced CT. Then to summarize, take-home points. Ultrasound is accurate to characterize ovarian masses with typical features. We can characterize cyst adenocarcinoma, but if we want to stage, then we have to go to CT or MRI accordingly. Serous and mucinous cyst adenoma, endometrioma is not atypical في الالتراساوند. في typical features, but usually you say it is a benign looking lesions, likely hemorrhagic, for follow-up to exclude endometrioma. You didn't give the diagnosis. Sometimes I found some of our colleagues said chocolate cyst. Chocolate cyst is not a radiological diagnosis. It's a pathological diagnosis. So endometrioma is not said on ultrasound, except if it is proven before that the patient has endometriosis, either by laparoscopy or whatever, but if not so, you just said that it is a benign looking echogenic cystic lesion في الأوفري, likely endometrioma. In mature cystic teratoma, the typical, I can say from ultrasound that it is mature cystic teratoma. If I found the typical signs, and you have another lecture for mature cystic teratoma on this channel, you have a look on it. When ultrasound is doubtful, MRI is the best examination for characterization. If you want to characterize, then MRI. For borderline ovarian tumors, it's very important because we use the functional MRI for borderline ovarian tumors. If you want to characterize the internal contents, we have 3 lesions that very, very accurate on MRI. Ovarian fibroma, teratoma, and endometrioma, we can diagnose accurately with MRI. CT has a limited role, but we can stage ovarian cancer. That known case of ovarian cancer, it's ORAD5, and just I want to see if there is peritoneal disease or liver metastasis or whatever, we can do CT scan. Characterization of a mature cystic teratoma and identification of PID or pelvic abscess of enteric origin. Then we came to the ovarian masses. Characterization of ovarian masses is diagnostic challenge. Why? Because the ovary is the common site for both benign and malignant neoplastic lesions. In addition, the ovary is a common site of non-neoplastic tumors, like retention cysts we always see every day, inflammatory cystic formation, and endometriotic cysts. Regarding the retention cysts, please don't overdiagnose. It's simple cyst by ultrasound, then follow up, then follow up, then follow up, except if it enlarge in size or become complicated. Then we have a non-neoplastic ovarian lesions, and this all we can diagnose by ultrasound accurately and no need for further examination. Follicular cysts, corpus luteum cysts, thecal lutein cysts, PCO, pregnancy lutoma, endometriosis, germinal inclusion cysts, and inflammatory cysts. All this can be diagnosed by ultrasound. Why I put the endometriotic cysts here? Because I thought it is some sort of functional cyst, because it shows functional endometrium. In these cases, MRI is very important for characterization. In these cases, CT is nothing. CT will be done, but no benefit from it. So MRI is very important for the ORADS 3, GYRADS 2, and GYRADS 3 lesions. In GYRADS 2 lesions, if they are persistent or enlarged on ultrasound, we can do MRI. And in 3 lesions, we want to characterize blood, fat, and protein. This can be characteristic by MRI. Note these cases. This a case I think we all can diagnose. It's just a hemorrhagic cyst. This case is a hemorrhagic cyst with fishnet appearance, which can be on the second cycle completely disappear. This is another case which seen apparently solid lesion in the ovary, but it is not solid because there is no vascularity at all on color Doppler. So this proved to be an endometrioma, but of different appearance. It's not the typical fine internal echoes that we see in endometrioma. And this case, guess what this will be? This is just a luteal face cyst, but it has the same fishnet appearance like the endometrioma and the hemorrhagic cyst, but this is not a hemorrhagic. It's just luteal face cyst. When I asked the patient, she said that this cyst ever appear in the second half of the cycle. So this is, and then disappears after the menstruation. So this is a luteal face cyst. But if we want to characterize, then we do MRI. And this is a picture show how the MRI characterization. This case, she has double admixal lesions. One lesion is bright on T1, suppressed on fat suppression, Fat suppression is very important sequence in the MRI because we can suppress bright signal في T1. So this is the T1 usually show the short T1 signal lesions like blood, fat, and proteinaceous material. This all can give high T1 signal, but of different appearance. And by experience, we found that they have different appearance. But usually we can do fat suppression in order to characterize fatty lesions. So this is immature cystic teratoma, bright on T1, completely suppressed on T2, and no contrast enhancement in the post-contrast. But here in the post-contrast, we have to take subtraction film, because if it is bright and there is a small enhancing component, you will not see. So we subtract the film, نعمل subtraction. The only enhancing component that can be seen on MRI. Regarding the other lesion, the left one is hypo-intense on T1, يعني relatively hypo-intense في T2, not suppressed, يعني ما هو hypo-intense أصلا. And here on the post-contrast, it takes very faint contrast enhancement. Low T2 signal means benign lesions, fibrous containing tumors like ovarian fibroma, fibrothecoma, all the fibrous ovarian tumors will be like this. So here, you know what is meant by MRI characterization of lesions. Okay? This is the normal uterus, normal zonal anatomy, there is no problem. Again, this is a case of endometrioma. We have here the endometrioma is bright signal on T1 and shading effect on T2, and then it is not suppressed on fat suppression, so this is blood. And we have here other diagnostic criteria for endometriosis في الMRI. نلاقي في dark spots, T2 dark spots, one of the characteristic sign for chronic blood. So this is an endometrioma in the ovary. But not all cases of endometriosis like this. Here another case, it is bright signal on T1, but it is heterogeneously bright and low signal on T2, not the typical shading effect we see on T2. So the shading effect depends on the concentration of the blood products. Hemosiderin-laden macrophages combined with the fibrous nature of the cyst will give the low signal intensity appearance on T1 and T2. Okay, so this is another case of bilateral endometriomas in the ovary, not suppressed on fat suppression. طيب, is there a specific MRI technique when I suspect endometriosis? Yes, we have two advanced MRI techniques that are specific. Sometimes we have a case of endometriosis but not so typical. Here, this is a typical case of endometrioma, bright on T1, shading effect, shading يعني تطفي, يعني low, shading effect on T2, and with dark T2 spots. This is the typical appearance of endometrioma. Another one here, it is bilateral. We have also adenomyosis in the uterus, and usually internal endometriosis. Usually endometriosis will be maybe endometriosis everywhere. So here there is adenomyosis with the typical bright T2 spots in the myometry. But sometimes they are not so typical, and in these cases we need new MRI technique to assess endometriosis. Like this is high T2 star. يعني ده sequence في MRI that we use it نسميه susceptibility weighting imaging, which has a very specific to the hemosiderin deposition. So we found here the dark T2 spots more apparent on the T2 star. And the diffusion weighted images. On the diffusion weighted images, this is very important to diagnose, to differentiate endometrioma from just a hemorrhagic cyst. The endometrioma is a chronic process. So we'll find that it is, here this is the sequences. It is bright on T1, shading effect on T2. Very important to comment on the residual ovarian tissue in order that the clinician, you know that the ovary is still preserved surrounding or not. And it is restricted on diffusion. What is the restriction? It has chronic blood products. So these chronic blood products بتخلي diffusion of the water molecules restricted, like in the malignant lesions. So we will find that restricted diffusion هنلاقيها bright في diffusion signal ولو في ADC map, and this بتبقى specific للendometrioma. But in the hemorrhagic cyst, usually it is acute process that may subside and gone after some time. So we'll find that it is bright signal في T2 في T1, bright signal في T2, and not restricted on diffusion. So this is the two MRI techniques necessary to diagnose endometriosis. Diagnosis and characterization by MRI. هديكوا examples كده. This is a case of ovarian أو adnexal echogenic cystic lesion. What to say from the ultrasound? That it is a benign looking cystic lesion because it is devoid of vascularity. Although it appears as if it is solid, but it is devoid of vascularity. So it is benign looking echogenic cystic lesion. Again, I couldn't say endometrioma from ultrasound. Then we do MRI. Yes, MRI is characteristic for blood signal. In the T1, there is hyper-intense signal peripherally. So this is subacute blood. It's not so bright as in the first case, but there is bright signal peripherally. And this characteristic for the blood signal. So this is blood. It is heterogeneous في T2. Here it is bilateral. So this is endometrioma. And it is restricted in diffusion. In this lesion, it is bright signal في diffusion weighted image and low في ADC map. So this is restricted also on diffusion. So this is endometrioma. And this is a nice table here to show how we diagnose by MRI according to the different sequences. T1 fat suppression, here low, bright on T2, and there is no enhancing lesions on post-gadolinium, so this is just a simple cyst. Hemorrhagic cyst will be bright in T1, bright on T2, bright on fat suppression, and no enhancement. في السبتراكشن بقى زي ما قلنا. And then endometrioma, it's bright on T1, bright on fat suppression, shading effect on T2, note the difference, and no contrast enhancement. Mature cystic teratoma is bright in T1 but suppressed on fat suppression, relatively low في T2, but not like the shading effect of endometrioma, and no enhancing lesions. But in the presence of cystic lesion with solid component, we will find an enhancing solid component inside. Again, when we search about enhancing solid component, please do subtraction. You must do subtraction film. Another case. We have here a case of, again, ovarian, benign looking lesion because there is no vascularity, although it's a typical appearance. And this is the MRI. It is just an endometrioma. Again, it is an endometrioma. So here, this is bright signal on T2, subacute blood on T1. Here, residual ovarian tissue in the periphery. This is the follicles, what we say ovarian peak sign. And this is a simple cyst on the other side. This is simple cyst on the other side. MRI is more accurate in mature cystic teratoma. الفات بيبقى hyper intense في T1. This is hyper intense في T1. Relatively hyper intense في T2. This is the appearance of the tooth on MRI. The crown is hypointense like this one. And this is the appearance on fat suppression. The lesion is completely suppressed on fat suppression. Regarding ovarian fibroma, MRI is very important. Low signal for T1 or T2, but sometimes there is associated high signal areas due to the presence of cystic degeneration. This is the ovarian fibroma, low on T2. طبعا عشان نعرف T2, this is the fluid in the urinary bladder, so this is the T2 sequence. And here it is homogeneously enhancing on post-contrast. So, just to summarize, if you have T1 bright signal mass, we must do fat suppression. If we have loss of signal, then this is immature cystic teratoma. If there is no signal loss, then and shading effect on T2, then this is a hemorrhagic lesion. يعني endometrioma بقى versus انها just hemorrhagic cyst بالdifferent differentiation that we have seen before. والhistory of the patient of course. طيب, if we have T2 solid mass, adnexal, احنا يعني نتكلم على adnexal. Just be sure that if it is arising from the uterus, because it will be subserous fibroid, or it is ovarian, homogeneous dark T2 signal, then it is a benign stromal lesion, fibroma. If it has mixed signal, no, we have to go to اللي هم مع cystic with solid lesions. We must know the tumoral enhancement, the degree of enhancement, the presence of septi, because we have an entity to differentiate. It is malignant or borderline or benign. We have to state this in our report. Tumoral enhancement, malignant mass. If there is inflammatory enhancement, طبعا ممكن هندخل tubo ovarian abscess in this category. Just again to stress on the ovarian tumors by MRI. The role of MRI in detection of ovarian tumors, it can determine the site of origin. Here we have, this is the uterus, this is the right ovary, and this is the mostly left ovarian, because we have the right ovary here, it appears normal with dominant follicle, and this is mostly arising from the left ovary. يبقى assessment of the primary tumor, هل هو benign, borderline or malignant? This is, you have to state this, is it benign, borderline or malignant? And we have a scoring by MRI like the ORADS classification. We have ORADS by ultrasound and ORADS by MRI. I can say ORADS 4 if I suspect towards borderline or malignant. If it is typically malignant, I will put it ORADS 5. And if I don't, benign to borderline, I put the entity regarding the patient age also. If the patient is old age, I am inclined more to be a borderline tumor. In malignant masses, very important to see the pattern of the extra ovarian spread. Note here regarding the site of origin, this was a case, 12 years old female, coming with a huge pelvic abdominal mass, not seen here, I will show. But the nice in this case that it is bilateral, and this is the ovary. Note here, this is the normal ovary, as I tell you before. We have the normal follicles, and this mass is arising and protruding from outside one of the follicles. So here, I say that it is not just ovarian mass. No, it is an ovarian mass, likely germ cell tumor, because it is arising from the follicle itself. So it is with germ cell tumor, and it is compatible with the patient age. So this is an ovarian exophytic soft tissue tumor. Of course, this case, she has a very huge mass on the other side, but important to detect bilaterality and to know the site of origin of these lesions. Another case, apparently it may appear as ovarian because it has the typical appearance of mucinous tumor. It has relatively bright with T1, relatively bright with T2. It shows papillary projections inside. Benign looking because I think these papillary projections are so small. But is it ovarian or not? We have to trace. No, it's not ovarian because the normal ovary is seen beside this lesion. This is the normal ovary. So here it is not ovarian. It proved to be a peritoneal cyst adenoma. Peritoneal cyst adenoma. So we have a lot of differential diagnosis, and I have another lecture for the non-ovarian masses. It's very important to diagnose non-ovarian from ovarian masses. In solid adnexal masses, the very important to differentiate uterine from ovarian by the CLO sign. This is uterine that I have shown you one case before, and the peak sign in the ovary, and the bridging vessels sign in uterine subserous fibroid. MRI imaging of ovarian masses, I want to highlight another important entity, and I hope that you request this in your request. When you ask for MRI, ask for dynamic MRI for the pelvis, in order, especially if we have an ovarian mass that we didn't know its entity. Is it with borderline or with malignant? You must do dynamic MRI imaging. A conventional imaging, that I have shown you, T1 weighted image, T1 fat suppression, and all the sequences of T2, all the scans of T2, because the T2 that show you the normal anatomy, sagittal, axial, and oblique, and coronal. We have to do all this. Because in order, for example, if I want to see is a serous fibroid or ovarian, I have to show all the sequence, because sometimes I found a pedicle, a very small pedicle coming in only one sequence. But what about the functional MRI? The functional MRI is the dynamic enhanced MRI. What is the dynamic enhanced MRI? That I give contrast, and then I take sequences on these contrasts from 1 to 8 minutes in order to see if this lesion is markedly enhancing lesion with washout, this is with malignancy. But if it is rising enhancement, then it is with benignity more. And at the end, we give a score of all these lesions with each other. And the diffusion weighted MRI, this is very important, and we have to request on all sequences because it is a short sequence, and we can يعني diffusion weighted is very important in the adnexal masses. MRS يعني a little bit difficult to do, but we know the chemicals that increase with malignancy and the chemicals that did not increase with malignancy. We have many MRI criteria in detection of malignancy: mass size more than 4 cm, bilaterality, mass predominantly solid, except for those of low T2 signal, and all predominantly benign. Necrosis in a solid lesion, cystic lesion with wall or septi more than 3 mm, and the presence of papillary projections. All those primary findings indicated that they are malignant. Secondary findings, we have ascites. Presence of ascites, sometimes ascites may be with benign lesions like ovarian fibroma. Like if there is suspicious lesion with ascites, then I suspect that it is maybe there be spread. Peritoneal metastasis and the presence of lymphadenoid. This is a case, 60 years old female. She has complex adnexal lesion. We have to know from which side it arises, because it is enlarged and it becomes pelvi-abdominal. But here when we see that it is arising from this pedicle on the right side, then it is right ovarian. And then when we see the ovary, it is a small postmenopausal ovary, but we can see this is the iliac vessels, and this is small postmenopausal left ovary. So I have here malignant mass, multilocular with enhancing solid component. شايفين ده البوست contrast, this is the enhancement with enhancing solid component in 60 years old female, so this is malignant. This is ORADS 5. But there is no ascites, there is no peritoneal implants, and we have normal left ovary. This is important to state in your report as a radiologist. And we must all know the staging of ovarian malignant lesions: stage 1A, stage 1B, stage 1C. Nice for the ovarian that any spread to the surrounding structures, consider 2. يعني if it is attached even to the urinary bladder or to the vagina or to the rectum, it's still stage 2, not like the uterine lesions, the endometrial and cervical. So this is very important. Capsular disruption 1C is very important to say, because if there is capsular disruption, maybe there is malignant cells and we have to go to a laparoscopic staging or laparotomy staging during this. Stage 3, if you have spread to the retroperitoneal lymph nodes or spread to the tumor to the peritoneum in the form of peritoneal deposits, this is stage 3. Stage 4, if you have distant metastatic lesions like lung metastasis, liver metastasis, and so on. The entity of borderline ovarian tumor is very important. It is a diagnostic dilemma, usually in the young age group, comprise 15 to 20% of ovarian epithelial tumors. They are histologically characterized by epithelial tumors with stratified gross pattern but without destructive stroma. Serous and mucinous neoplastic lesions constitute the majority of these borderline tumors. The presence of PID on MRI is very characteristic. This is the characteristic appearance of tubal part. If you can see the ovary, you can see that it is tubal only, or if the ovary is encountered in the process, you say that it is tubo-ovarian complex. So this is the typical appearance of dilated fallopian tube, either hydro, hemato, bio, all this we can see. And this is a differential diagnosis of adnexal masses. This is epidunculated subserous fibroid. This is low signal on T2, but it is uterine in origin, because I can see a pedicle coming from the uterus. So this is epidunculated subserous fibroid. In malignancy, CT and MRI, very, very important to see the degree of enhancement, presence of pelvic carcinomatosis. Very, very important usually to assess for bowel invasion. Don't see only the metastatic lesions and you didn't see that it is invading the sigmoid, for example. So very important to trace the bowel in order to see if there is bowel invasion or not. Peritoneal carcinomatosis is located above or under the liver, because it's important on staging and the presence of other metastatic lesions. This is a borderline ovarian tumor. The ovary is bulky, but it's not so much enlarged, but there is solid component that is vascular on color Doppler, and here it is inside the follicle. Note, there is still inside the follicle, so this is a very small borderline ovarian tumor. Diffusion weighted imaging, this is very important. Diffusion weighted imaging, just we see the movement of the water. If it is restricted in many cases. Of course, first in malignancy. The diffusion is restricted in malignancy. This is a primary lesion that is low, but it has restricted diffusion, so this is a recurrent mass post-operative. This is very important for the characterization of primary lesions. For the presence of deposits. If I have a small deposit, it is highlighted on diffusion weighted images. So this is a peritoneal implant, and شايفين هنا هي high on diffusion and low on ADC map. So this is a peritoneal implant. So usually, in detection of metastatic lesions, please look on the diffusion weighted images. Lymph node assessment. This is another small lymph node which is restricted. So we have to write, although it appears as it is subcentimetric, but it has no lucent hilum and it is restricted in diffusion, so it warranted to take it into consideration. Differentiating residual from recurrent disease. This is very important. This lesion appear in a case that is coming for follow-up, but on doing diffusion, it is not restricted on diffusion, so this is just a fibrosis. MRS, what is MRS? MRS, we know the chemical constituents of the lesion. Just to remind that in the pelvis, it shows increase in lactate and alanine peaks together with low glucose in malignant lesion. يبقى في malignant lesions we have elevated lactate peak and alanine peak. لكن low glucose. But in benign lesions, absence of lactate, this is very important that it is towards benignity. Of course, طبعا with other criteria seen on MRI. This is the dynamic contrast enhanced MRI. Sometimes we do color overlay in order to see the color pattern in this lesion. This is very important also to exclude the nature of this malignant lesion in the pelvis. I will give you an example in order to see why to do all sequences. This case was 15 years old female. She has right ovarian mass with multiple enhancing papillary projections, and there is absent lactate peak on spectroscopy. And on dynamic contrast enhanced, no, here in the dynamic we know the time to peak, the washout curve, we calculate all this. And the curve is rising. This is benign curve. We have 3 types of curve, and this is benign curve. So this is towards benignity. But of course, due to that, I fear that it may be borderline because we have a large solid components. But as we all see the previous jar we see in the pathology department of the papillary serous cyst adenoma, this is the appearance of papillary serous cyst adenoma. And it was the pathology revealed papillary serous cyst adenoma. No need for further assessment, for follow-up, and then okay. So ovarian lesions detected by ultrasound, functional anechoic cyst less than or equal 5 centimeter. Please don't ask for other investigation. Just repeat ultrasound, repeat ultrasound, repeat. I have many cases that became pregnant while the cyst is present and no problem. If complicated or increase in size, then go to MRI for characterization. If we have complex cystic lesion with no solid part, again, we can do MRI for characterization. Is it PID or borderline ovarian tumor? We can do MRI for characterization. If we have complex cystic and solid lesion, we can do MRI for staging, but we must do dynamic and diffusion. If it is purely solid, if I found it low signal on T2 and diffusion low also, then it is benign lesion, fibrous tumor of the ovary. Maybe I cannot do contrast. But if it is purely solid, then I must do contrast in order to show the behavior of this tumor, not only the morphology, but the behavior of this tumor. Okay, I will stop at the adnexal, and next lecture I will do the uterine, inshallah. Thank you for listening.